Yeah, I want to start with who should be tested with which technology, and there we look for genetic markers, that is NPM1, fusion oncogenes, also acute promyelocytic leukemia, and these patients should be tested with RT-PCR. And for the other patients, you should look for a leukemia-associated immunophenotype at diagnosis. And if it's present, then you should use the flow cytometry as a technology. Now, of course, the question is, how to combine the results? I mean, we know that RT-PCR is more sensitive than flow cytometry. And how do you combine the results? Some studies looked at both technologies and made an interesting observation. So if both technologies are negative in a patient, then the patient has the best prognosis. If one of the technologies is positive, then you have an intermediate prognosis. And if both technologies are positive, then the patient has the worst prognosis. And how we act on that in the future has to be resolved. But I think there's a clear prognostic message from these results on which the physician can act. Now, of course, the problems with the sensitivity, or the question about sensitivity, as I said, RT-PCR is the most sensitive, but you need to control it in every assay. You need to see how much DNA did you use, how much cells did you use, and you can read out and should report your sensitivity for the individual patient. Flow cytometry, you need a lot of cells to analyze, and an important point is for the treating physician that you use the first pool of bone marrow for MRD analysis, so not to dilute the sample with blood. And for NGS, we are still standardizing and finding out what would be the best method and approach to achieve maximum sensitivity. And there, I hope, will be guidelines in the future.